I'm by training a psychologist and social worker and a nurse practitioner. I do psychiatry and family medicine as one of the faculty in the residency program. And I work with Tufts, UNE, and UVM medical students who come here for their clerkship rotations and third years. So yeah. And
Thank you, Patrick.
Yeah. Are we good to go?
It looks like it.
All right. So I decided just to present what we've done in the residency program, which is a portion of what family medicine or primary care practices are doing within our system related to screening, just so that, I don't know, if anybody thinks it's interesting, it might be something we can talk about. It's kind of one of the things that I take some pride in, because when I first got to the residency, frankly, a decade ago, I didn't know anything about graduate medical education, but from a graduate student perspective, I mean, you know, most doctoral preparation requires, you know, theory and philosophy. I mean, there's a reason why the PH in, you know, in a doctorate is about philosophy. So I started asking a lot of questions about, like, what is the philosophy of family medicine? What is the philosophy of primary care? And what is it that we're actually doing? Out of all of that came a really interesting discussion about a branch of philosophy called phenomenology, which is about getting at the patient experience. Because there's a saying in psychiatry that it doesn't really matter what happens to somebody, it matters how they think about it, it matters how they feel about it, it matters how they you know, respond to it. And if you don't understand what the patient experience has been, you know, we can do a lot of you know, powerful things sometimes with meds, but make very little difference in people's lives. And prior to that, the decade before, I had learned about things like ACE scores and some other things, and I'll just share about that in a minute. So it was out of thinking about what is a philosophy of primary care practice in family medicine that could be meaningful, and how is it that we can best get at patient experience, you know, to better understand the patient. So next slide. So I don't have any commercial conflicts, but I am doing a study related to ACE scoring in primary care settings right now with the Dartmouth Research Co-op, and we have a grant that funds that. And we're also pilot testing right now a adult violence experiences scale, which I'll share with you in a minute. And so those are research conflicts that I do have. And my goals today are just to talk about the overview of ACE scoring and adult violence experience scoring in primary care practice. And, you know, and then to have a discussion with you about ways that you might pilot or test such tools in your practices if you're interested. So next slide. Okay, I want you to just to take in this view for a minute. Just imagine all of your senses, taking in what it might smell like, what it might taste like, what it sounds like in such a place, and just take this in as a bucolic, beautiful sort of main moment. And think about how you feel. Notice what it does to your body. Take a nice deep breath and imagine that ocean air for a minute. And next slide. Take a look at this. Now, what does this do to you? What kind of an experience do you have? And there are certain people that this might provoke a lot of different feelings about from. You know, this might provoke some anxiety. It might be kind of exciting, but it sort of depends on you know, your orientation to risk, if you will. And by the way, I use this in our Intro to Family Medicine course. Some of the residents print out the next slide just to remind them about different patient experiences, because it's so illustrative. So next slide, please. So I just want you to notice this great picture of these families on the roller coaster. And notice that in the first car, there is, I mean, well, I don't know, what do you see? I'll ask you. This will be participatory for a moment.
Fear.
Fear, yeah.
Fear? but that mom is doing everything she can to protect her baby in the first one. But I also want you to take a notice in the second car, the one that's right behind. What do you notice there?
She's smiling.
She's smiling, she's engaging the child, and I want you to just imagine the different experiences that are potential between these two kids based on, you know, the orientation that they come to this with, right? So next slide. So I'm assuming that probably everybody here knows about ACE scores, but it's a really interesting, you know, it's an old study now, really, but it's sort of funny to me because it's one of the few things in medicine that gives us predictive curves that sort of look like an L. And there's very few things in medicine that are as predictive in terms of, like, you know, a robust predictor of all the things that Vince Felitti talks about: course chronicity, cost, morbidity, mortality, and yet, in most primary care settings, what we get for standardized questions or meaningful use is something about domestic violence, which is that HIT score, which I don't know who named that domestic violence screen the HITS tool, but you know, and oftentimes that doesn't even get asked by the provider. It gets asked by somebody when they're rooming a patient, and it's kind of a sad thing. And because I think, I mean, oftentimes when we've done research about this, patients assume that because the MA is asking, or because it's on a piece of paper that somebody might get, or even on a tablet that somebody might get, it's a piece of information that is in the background, that it's not important enough for often the physician to be asking in the room, or the provider to be asking in the room. So what we did was, you know, teach everybody about ACE screening, and then made a form within the electronic medical record so that it pops up in the medical record now, like a reminder about, you know, somebody who might have allergies, or you know, something like, it's a pop-up reminder. Because the research is pretty clear that if you treat the issue of violence in a chronic disease model, you know, you can reduce future incidents that people experience as violence in their lives. The most remarkable thing, and the thing that the residents often are surprised by, is how predictive it is of future violence. So people who have an ACE score of 4 or more are 9 times more likely to experience sexual assault in the future, and 6 times more likely to experience or to choose a violent partner in the future. And it turns out that if physicians and providers ask about these things, and then ask in follow-up about these things, it reduces the risk of future sexual violence and or physical violence, domestic violence. There's pretty good data on this. So, I'm assuming, but I don't want to assume that people know basically what the ACE score is. And interestingly, the history of it, I mean, you know, the Kaiser Permanente study, you know, that brought all of this together was done in a weight loss clinic in the days before all the hospitals made millions of dollars doing Da Vinci surgeries for bariatrics. You know, we did in primary care this thing called supplemented fasting. But there was always this subgroup of people who would gain back not just all of the weight, but all of the weight plus, and or who would sometimes become psychotic when they had significant weight loss, which is sometimes explained as the loss of a defense mechanism for people. And so Felitti was moved to study this with Robert Anda and another group, an entire group of people, an entire team of people, to take a look at why was it that folks had, you know, often such poor outcomes, you know, when they did lose a significant amount of weight using supplemented fasting. So they tested, I think it was several hundred questions, but, you know, these were the 10 that they settled on. And so does a parent or any other adult in your household, and this is basically, I'm going to do it right now as if I was asking a patient. And one of the things that patients tell us is that if you ask the questions in this way, it tends to be not triggering for people. People can tell you yes or no, and then move on, and they don't have to really talk about these things. But that a parent or other adult in the household often or very often swear at you, insult you, or humiliate you, or act in a way that would make you afraid that you could be physically hurt. 2, did a parent or other adult in the household often or very often push, grab, slap, or throw things at you? Were you ever hit so hard that you had marks or were injured? 3, did an adult or a person who was 5 years older than you ever touch or fondle you, or have you touched their body in a sexual way or attempt or actually have oral, anal, or vaginal intercourse with you? Did you often feel that nobody in your family loved you or thought you were important or special? Or was it like your family didn't look out for one another, feel close to one another, or support one another the way you think that a family should? Did you often feel that you didn't have enough to eat or had to wear dirty clothes or had nobody to protect you? Or were your parents ever too drunk or too high to protect you or take care of you if, like an example, if you needed to go to the doctor? Let's see. Is the voice still distorted?
It is.
Oh. Is it distorted for you, Peggy?
It doesn't, it's not clear. It's garbled.
Oh. Help me. Is it for everybody garbled?
Yeah, I can hear it a little gargly.
I just muted. I'm gonna mute Peggy real quick and just see. I think it may have been a little bit of feedback. Just, I'll mute everyone in the line and let's see if that's better.
Okay. Testing 1, 2, 3. My radio voice. Is that better?
Yes, I think that's better. If anyone else thinks it's not, let me know.
Okay. So the last question was 5 about, did you feel that you didn't have enough to eat or had to wear dirty clothes or nobody to protect you, or your parents ever too drunk or too high to take care of you or take you to the doctor if needed, as an example? Your parents ever separated or divorced? Your mother or your stepmother often or very often pushed, grabbed, slapped, or had things thrown at her? Sometimes, often, or very often kicked, bit, and hit with a fist or hit with something hard, or ever repeatedly hit for at least a few minutes or threatened with a gun or a knife? Did you live with anybody who was a problem drinker, an alcoholic, or used street drugs? Was a household member depressed, mentally ill, or did a household member ever attempt or commit suicide? And the last one is, did a household member ever go to prison or jail, or we ask it, were you ever, or were they ever taken from you, or were you ever removed from your family? So I'm assuming everybody knows these, but we found that if you ask, matter of fact, yes or no questions, people give you a significant amount of information and feel good about it if you survey them later. And if you ask them permission to follow up about how they're doing with these things, people will, often give permission and appreciate that. And the problem with the ACE score was always that it's, this is when you were growing up to the first 18 years of life. And that's how this has always been studied. So any thoughts or questions or feedback or musings about this?
Do you find that this screening tool is used a lot more in family medicine practice, or is it more used with pediatric?
Well, we use it here with the family medicine residents. So we have a large 60-person practice, and there is 2 of the 7 family medicine sites are using it. The pediatricians in our system, like Jan, oh my God, who's the peds dermatologist? Jan, she was the president of the AAP here. Like, the pediatricians have trialed it, but some like it and some don't. So there's variable use in our pediatrics practice here. So most of the people that we use it with in family medicine tend to be adults, reflecting on this in the past.
We're actually started a community project led by one of our pastor with it's called the Van Buren Resiliency Project, and it's based on the ACEs. Mm-hmm. So what we're doing now is gathering all the resources first. It's still a pilot project that we're doing, and we're trying to get the community together. So when we do start screening, because the second part of it is to get the providers involved to do more consistent screening of this, and that way we have the resources in place to refer them to.
Yeah.
So it's, I mean, it's pretty good. We just watched the movie Paper Tigers. I don't know if you. Yeah.
Yeah. Yeah. Just for those of you as a reference, the Maine Resilience Building Network has been a great resource, you know, for communities around ACEs and focusing on the resilience part of ACEs and, you know, that sort of thing too. But I can send you more information about that. Should you like.
Yeah, we're part of that network too. We've signed up for like grants and more assistance.
Good.
Yeah, it's, I mean, it's very interesting, and from our side, I don't see this screening tool used like frequently.
Yeah, I don't think it's been powerful. I also cover at Acadia and just inpatient psychiatry and obs medicine over there. Well, I'll talk about that in a minute, but the patients, the feedback from the patients and, you know, both research-wise and anecdotally have been that they appreciate that they don't have to hide these things and that it seems to help with stigma. And Vince Toletti, you know, this is unsatisfying to a lot of people, but Vince Toletti often said, you know, the power of the intervention is just in asking about it. It means, you know, I mean, not everybody, you don't have to tell the truth. You don't even have to answer all the questions if you don't want to, but it's been kind of interesting how it's worked, you know, practically speaking. And it's made a big clinical difference because at least the physicians and providers here feel that they really get a handle on who the patient is. And then oftentimes the patient asks to talk about these things later in subsequent follow-up. So next slide. So this is the Haven scale. Now, mind you, we are scratching the surface of testing the public health language about this, like messaging and all of that sort of stuff. But one of the unsatisfying pieces of the ACE score was always that it, you know, it's static, right? So like up to 18 and then it's done, and then your score is your score. And it seems incredibly predictive and it's been incredibly powerful. But we also wanted to get at adult violence experiences. And this is a quote from, you know, for probably the last 20 years in public health efforts, you know, led by Deborah Prothero-Steth and some of our surgeons general. You know, the notion that violence is actually a, you know, a public health interest. It's not a, I mean, we haven't done very well trying to treat violence with law enforcement. And because it underlays so much chronic disease and psychiatric illness, you know, trying to get, you know, more of the patient story and then doing something with that, you know, there's a pretty good literature supporting this powerful intervention. So this is our attempt at getting at the adult violence experiences of folks. And this uses the World Health Organization definitions around, what do they call them? It's how it is that they define violence in three main categories. That's self-inflicted violence, interpersonal violence, and then collective or community violence. So, you know, this asks questions about intentional self-harm and or suicide, adult experiences of physical and sexual abuse, and or just the threat of such things from partners. Like, so it looks at both in the family or outside of the family. So from within the family, like a partner or family, or outside the family in the community. Have loved ones ever, you know, done things that were controlling or restrictive of you? Or have you ever had, you know, outside people do that to you? Have you been subject to threat, intimidation, violence, again, within a family system or, you know, in a community sort of system? Have you been exposed to abuse, intimidation, neglect in a living situation? If you live somewhere where you're subject to violence, crime, or you had significant fear or felt a lack of safety there, have you worked or been exposed to violence, neglect, intimidation, or discrimination? And this isn't the exact language, but these are just the topic areas. Have you been exposed to war, genocide, political violence, prejudice, which includes all of the, you know, the isms and the homophobia and those sorts of things? Abuse, intimidation, threats, neglect on social media or internet experiences, And what that we find, I mean, this has just exploded. And experience violence due to prejudice about who you are. There's a concept called epistemologic genocide that we're lucky we have 2 Native American faculty here. And one told a story about, Lakota teachings about being related to all things, including plants, and that there was this child who was always taught by his mother and his grandmother and his father about talking to plants, and then went to school and in 2nd grade, talked about his conversations that he was having with plants in his environment. And the teacher said, "You can't talk to plants. People don't talk to plants. Plants don't talk." And that bit of cultural violence is really what psychology and philosophy would call an epistemologic genocide. Like, who you are, your conception of the world does not count. And that's a pretty interesting experience of violence that has been written about for 10 or 15 years, but to bring it into healthcare is an interesting idea. And then also, the last question is significant, salient too, because so much of the people that we see in primary care, we tend as healthcare providers to be quite enamored with ourselves as heroes. And we feel different when it comes to talking with a perpetrator of violence, or somebody who may have committed sexual abuse or been a perpetrator of family violence. There's a different feeling in the room, when you're dealing with a perpetrator. And the sad part of that is that we're in this key position to actually make a difference by connecting with those people. And this goes to the quote that's at the side of the slide that Rich said in the public health setting. We have to just remember that it's hurt people who hurt people. And if we think about that just philosophically for a minute, maybe the next time you see somebody who's been convicted of child sexual offenses or something like that, we'd be more willing to ask about their experiences and who they are now than avoiding some of that stuff. The last question, this goes to have you done anything that you regret, or are there things that make you feel weird, sad, ashamed, or embarrassed, or that when you look back on it you just wish didn't happen? Or do you ever fear that you might hurt other people? And there's really interesting research, public health-wise, about that from programs like Stop It Now, which, when they started 10 or 15 years ago, people all thought was crazy. But Vermont had a Stop It Now program where and they framed it all around touch. If you ask people, have you ever been sexually abusive to somebody? Nobody will answer that question because the stakes are so high. But if you ask people questions, have you ever touched somebody in a way that you regret or that you wish hadn't happened? It turns out that people will answer that question. And so in a Stop It Now model, they reached out to and did public health messaging around this, asking people about, do you want to stop being abusive? And it turned thousands of people called 800 numbers, and they had a procedure where somebody could get an attorney to protect their rights, but the intervention began immediately with the call. And it's a really interesting public health way that doesn't, much of our messaging about like kids, has put the onus on kids to report sexual abuse, or is, how is it that we directly reach out to people who might be struggling with their own experiences of violence? And that question number 12 is an attempt to get at that. And it's been really interesting, teaching and, collecting data about this in a primary care setting. But so any thoughts or questions? And I'd be happy to send all of this to you because this is really in the first stages, and it's probably a couple of years away from like, a first trial. But so right now we're in like focus groups and that sort of thing. But any thoughts or questions about this as a screen?
What's the cutoff? Like the ACEs, if it's greater than 4, what's the cutoff for this one?
Well, that's the thing. Like we won't know that. I mean, that's a 5-year question, right? So what we're getting at, like we're trying to make it useful as a screening tool, and then that kind of data. I mean, please help because well, in a couple of maybe in the next year, as we run it through the co-op process, it'll be ready to start being tested. But if you wanted to be part of a testing site, we'd probably start collecting data on this in like 2 or 3 years. I mean, plus, we need to get funding. I mean, there's a chunk of work to be done on this, but yeah. Just starting, don't know. It might be useless, but that's possible too. We don't know. Any other questions or thoughts?
Patrick, at what point do you use these? Is it just on an intake, or how do you bring it in after you've been seeing the patient for a year or two and you enter that conversation? Like you said, the actual asking is part of the intervention.
Yeah, great question. And so we try to do it with all new patient and all new patient encounters. We try to do it in annual visits, because it turns out too, especially with white men don't like to talk about, embarrassing things and all of this stuff. It turns out if you ask people these questions 2 or 3 times, I mean, I have dozens and dozens and dozens of anecdotal examples where I would ask specifically, especially about sexual abuse, because there's so much like people, older white men believe that if they have been sexually abused, that means something about their sexual orientation has sort of been a thing. When we ask people at annual visits, like sometimes it takes like 2 or 3 times, especially white men, to be able to talk about experiences of sexual abuse. So it's been rich that way. But so the answer is, you've already been meeting with somebody. We teach the residents often that if something medically just doesn't make sense, and oftentimes things medically don't make sense, that we probably don't know the patient's story very well. And so this is a tool in phenomenology of getting at patient experience. And people are like, well, what's their, like here now, people are walking around. Oh, right, this patient has an ACE score of 6. Oh, right, we're going to go to the surgery. They have an ACE score of 9. Oh, right, well, we have to remember this when we're formulating our treatment plan. We're going to ask the patient about their experience related to these things, because in the chart, it pops up and it says ACE score 6 of 10. And everybody here knows what that means. So like if it's somebody that you're working with for a while and you just haven't used it, I introduce it by saying, we're now doing this with everybody that we see. It's not special about you. There is nothing shameful about this, but it's like, these are important things that we know that tell us something about how your brain is wired, how your HPA axis is wired, the amount of cortisol that's likely in your blood, how it affects your immunity, and it certainly underlays most psychiatric presentations. One of my famous psych researchers is a guy named Colin Ross, who's a little bit wild, but I mean, there's like a 0.8 correlation between what would you would say probably that schizophrenia is the most genetically determined of all psychiatric illnesses, perhaps, and yet there's like a 0.8 correlation of experience with violence and turning on those genes for schizophrenia. So the fact of the matter is, understanding people's histories of violence and violence experience, like I believe 10 years ago, I was an anthropologist about this. Now I'm more of an evangelist. But the fact of the matter is, violence is sort of like the missing link, and we dress things often in terms of like a biomedical sort of presentation, and miss obviously the psychosocial presentation that underlays, a lot of psychiatric presentations. I think it's immoral to not know these things, or at least not ask them with your patients. So did that answer that question? Okay, next slide.
Patrick, we have about 10 minutes left, so I don't know how much more you have here.
Sorry. Oh, I'm very bad, aren't I? All right. So this is the thing I already told you about, why ACE scores matter, at least in a primary care setting. Next slide. I don't think I have much more. Oh, and so this just tells you all that what I just said. We have this as a pop-up in the system. It comes up with a reminder, kind of like patient allergies, so that you just don't forget to ask. Because patients don't like it when you ask about these things, and then we never ask them again until like another year. That's not good either. Although some patients will be like, I'm okay with this stuff, and I don't want to talk about this anymore. And then we make a note of that too.